So my name's Rohan. I'm a F1 doctor working in the east of England on the medical education AFP. Thanks so much for joining us again. We're just going to be running through the rest of the cardiology sections that we didn't manage to put in last week's session. So hopefully after this, we have a pretty good overview of everything that you need to know with regards to cardiology. It won't take the full 2 hours, so you'll be probably very pleased to know that on a Sunday evening. So really the things that we're going to be talking about, we're going to be covering hypertension in quite a lot of depth because it's important. We're going to be talking about some valvular diseases, rheumatic fever, infective endocarditis, and HOCM. And as before, we're going to be putting in quite a lot of SBAs. If you guys have got any questions, feel free to pop them into the chat. I'm going to try and leave questions to the end if possible, just because that kind of disrupts my rhythm a little bit. But obviously, if you do have anything particularly urgent, let it pop up. And if there's anything that I can't answer off the top of my head, then Mahersh and Shavini, if you guys can jump onto Google and we can make sure that we get a right answer for these guys, if that's all right with you. Is that cool?
Yeah, of course.
Brilliant. Thanks so much for the help. And right, let's get started with our first SBA. So this is an 83-year-old gent who's come into the GP practice for the results of his ambulatory blood pressure readings. Average BP at home was 145/87. He's got no other presenting complaints. His past medical history is significant for an appendectomy when he was 14. Based on the above information, what is the best management of this patient's hypertension? Amlodipine, bisoprolol, candesartan, ramipril, or just monitor him and see how it goes? And brilliant. That's it ended, isn't it? Brilliant. So the answer people have gone for is A, which is interesting. So a few things. So when I look at a patient, when I look at an SBA, the first things I look at are what is the patient's age. So he's an 83-year-old gentleman. He's come in for the results of his ambulatory blood pressure monitoring, which means that he's gone home and he's had some blood pressure tests at home. The average is 145/87, which is hypertensive. So he does have a high blood pressure, but it's not really that high. He's got nothing else wrong with him apart from an appendectomy when he was 14. He's 83. It's completely irrelevant at this particular moment in time. So because of this, the NICE guidelines actually say that we need to monitor this patient because he's over the age of 80 with a blood pressure of less than 150 systolic over 95, less than 150 over 95. We'll go into the whole nitty-gritty a little bit later on. But because of that, because there's nothing else wrong with him, we would actually monitor him for any sort of worryings, we just monitor him, see how the blood pressure is doing. Essentially what we're saying is that actually the reason this guy's got high blood pressure is just because he's old. It's not high enough that we're really worried about it, so we don't need to treat it. I know a lot of people got caught out by the amlodipine option. I did put that in there for a good reason. That would be there. We'll talk about the exact guidelines, but that would be first line if this patient was below 80 and had symptoms and a blood pressure of above 150/95. The rest of the options are options during your treatment of hypertension, but it wouldn't be because this patient doesn't meet the criteria, essentially, it's just monitoring. And we'll go into that in a bit more detail a little bit later on. So hypertension, defined as a blood pressure of about 140/90 or an ambulatory BP of above 135/85. The majority of the time, we don't know what's going on. So that's idiopathic, which is a posh word for we have no clue, or it's called essential hypertension, which essentially, again, means I don't have a clue. But there can be things that we're worried about. So there's endocrine pathologies, such as a pheochromocytoma, which is an adrenaline-producing tumor of the adrenal glands. Cushing's syndrome or disease, which is essentially, for some reason, this patient's got a lot of cortisol being produced, which is a stress hormone, and again causes your blood pressure to rise. Or this patient can have a renal problem. So the classic condition is renal artery stenosis. And this is really interesting. So how this works is that the renal artery, so the blood supply to the kidney is narrowed. So as you can imagine, this is after the stenosis, the blood pressure is pretty low in comparison to the rest of the body. So the kidney is effectively receiving this low blood pressure. So he thinks the systemic blood pressure is really low, and therefore it activates the renin-angiotensin aldosterone system, which work synergistically and systemically to raise the blood pressure. So that's why, and so therefore, even though this patient, so therefore the blood pressure which, in the entire patient, in the entire body is increased, because the kidneys effectively think I'm getting a lower blood pressure than it actually is. Also, things like pain and emotional stress can raise your blood pressure, as probably we've experienced in our own lives. But really, it's usually an incidental finding found upon a checkup. You can get these complications that can occur if you've got worrying levels of hypertension, like headaches, visual disturbance, kidney injury, and heart failure. And these all kind of make sense. You know, if the blood pressure is really high to your brain, then you may disrupt your brain. It may disrupt your eyes. If it's going really high to the kidneys, I kind of think of it like the kidneys are just getting a little bit, I kind of think of it like a balloon, to be honest, and you're stretching out the balloon. It's not quite how it works, but it helps in my head to be able to visualize it. And that can cause, the kidneys don't like being stretched out, and therefore that can cause kidney injury. And also, if the blood pressure is systemically high, the heart just has to work a lot harder in order to be able to actually push it against, to be able to supply the entire body. And that can, over time, that can cause the heart to fail. So hopefully that should be fairly self-explanatory to a lot of people, but just a bit of an overview if you've not experienced hypertension before or you have not seen it before. So in terms of a diagnosis, this is how we approach it. So initially the clinic reading, the patient turns up to the GP with a blood pressure above 140/90. After that, you decide to offer ambulatory blood pressure monitoring or home blood pressure monitoring at home, which is essentially they have a blood pressure cuff attached to them. They keep it on during the entire day, and that measures their blood pressure maybe twice every hour, etc. They take the average of those readings and see whether that average blood pressure is high or low. If it's really low, then the patient is not hypertensive, and therefore you just monitor them. If it's really high and the blood pressure is above 150/95, then you would treat that blood pressure no matter what's going on. But if the blood pressure is between these two levels, so between 135/85 and 150/95, then we would then do a little bit more stratification to figure out whether this person would benefit from treatment. And the stratification we do is that we treat if they're below 80 and they've got any of the following conditions: target organ damage, cardiovascular disease, renal disease, diabetes, or a 10-year cardiovascular risk equivalent to 10% or greater. And what that means is that you put their details into a Q risk calculator, which is something you get online. It spits out a number, and if that number is greater than 10, then you would treat. If it's less than 10, you wouldn't treat. And that's basically how that works. In terms of end organ damage, that always used to confuse me when I was a medical student because I had no idea what it meant. What it essentially means is that they've got hypertensive related damage to your organs at the end of, at the end of the circulation. So in terms of heart problems, that can be ischemic heart ECG changes. So your inverted T waves, for example. In terms of the renal problems, so you would maybe the kidneys are getting a bit more leaky or not functioning as well as they would do before. So you can do something called a urine ACR, or albumin creatinine ratio. And if the kidneys, if there's a lot more albumin in the urine, then it means the kidneys aren't able to filter effectively, and actually that albumin is leaking out, and therefore there's a problem there. And also you do using these just to make sure this patient hasn't having an AKI on you. And the last thing you'd want to check is the eyes. If there's a load of swelling in the eye, so papillary edema, or if there's signs of a load of retinal bleeding, then again, that indicates that this patient's got some degree of end organ damage. And this is sort of what we mean by all of these things. CVD risk, that's a Q risk score, as I just explained there. It's a calculator online. You put in the details, it spits out a number. If it's greater than 10, then you would treat. And also, the other thing you're worried about is if the clinic BP is above, if it's really high, above 180/120, then this could indicate there's a more serious problem going on. So you would send them into A&E if they've got eye issues, so this stuff, or the sort of things that would trigger you to be worried anyway as a doctor. If they're starting to have heart failure, if they've got AKI for whatever reason, when you look at their bloods, if they've got chest pain, a headache, palpitations, so things that you'd be worried about anyway, in conjunction with this really high blood pressure, you're going to be safe and you're going to shoot them up and blue light them over to A&E, okay? And I think that kind of makes a lot of sense, rather than, it's better to think about things as a logical process rather than try and remember all of this stuff. Basically, if you're worried about this patient, they've got a sky high blood pressure, send them into A&E. If they don't have any of this stuff, then you would try and investigate for if there's any degree of end organ damage. And so again, you would do an ECG, you may be doing an ACR, PCR, you would do it using these, you check the eyes. If you've got any of those problems that are going on, then you wouldn't bother waiting for 7 days while they go for an ambulatory blood pressure monitoring. You'd treat them straight away. And again, if you're really worried, you'd send them off to A&E. But if they don't have any end organ damage, and if they aren't having any of these issues that you're worried about, then it may be that this is just some sort of weird spurious result. So the guidelines say that you would come back in 7 days, retest the blood pressure, and if it's still high, then you would treat. If it's not still high, then you would, if it's still down here, then you're absolutely fine and you can move on with your life. Any sort of issues with regards to that so far? Or does this slide make sense to people? I'm really struggling to use Zoom, I don't know why. Okay, so I'm assuming that because there's nobody talking back to me, that's a good thing and people are understanding what's going on. Okay, so next question then. 73-year-old Caucasian gentleman comes into the GP practice for the results of his ambulatory blood pressure monitoring. His average blood pressure at home is 170/105. His past medical history includes hypercholesterolemia and type 2 diabetes. He has no known drug allergies. What is the most appropriate management of this patient's hypertension? Ramipril, candesartan, thank you. Candesartan, bisoprolol, amlodipine, or verapamil. Okay, brilliant. So people have gone for D as the correct answer. Right, so again, let's take a look at the question. 73-year-old Caucasian gentleman, that's so somebody who's got from a European origin, basically, has presented because of ambulatory blood pressure monitoring and he wants to know his results. His blood pressure at home is high, above 150, so he needs treatment. And his past medical history includes hypercholesterolemia and type 2 diabetes mellitus. He's got no drug allergies. Type 2 diabetes mellitus is important because if they've got type 2 diabetes, you will treat them with Ramipril, this irrelevant of the fact that they're older or if they're Afro-Caribbean, etc. So ACE inhibitor first line type 2 diabetes, irrespective of ACE, race and age. Again, we've got a load of different blood pressure medications that we can try out, but I will explain how they fit into things a little bit later on. But yeah, for this one, the type 2 diabetes, and the reason why is because Ramipril and ACE inhibitors have got good evidence in type 2 diabetes of being able to help with end organ damage. So that's the reason why you're giving the Ramipril as opposed to your other things that you would give. So candesartan, that's an angiotensin 2 receptor blocker. You would give that as if they're intolerant to Ramipril. Bisoprolol is one of the later line steps. Amlodipine is a peripherally acting calcium channel blocker, which you would use for hypertension. You would use that if they're over 55 or Afro-Caribbean with no type 2 diabetes. And verapamil is part of your Dilmil, so diltiazem, verapamil, which act on the heart, like Dilmil, the dating app. And those are your cardioselective beta blocker, calcium channel blockers, which you would use for heart failure, etc., to slow the heart down. For hypertension, you use the peripherally acting pines. So just a quick thing that one of my mates made up, and I thought that was pretty good. Okay, so another question then about management of hypertension. So 58-year-old Afro-Caribbean gentleman comes into the GP practice as his blood pressure is still not appropriately controlled. He has a past medical history of asthma, is currently on Ramipril, indapamide, amlodipine, and a rescue salbutamol inhaler. His ambulatory blood pressure is 143/90, and his recent USANEs are below. What is the most appropriate next step in this patient's management? Losartan, thank you, bisoprolol, doxazosin, spironolactone, or bendraflumethiazide. Brilliant. Okay, so the most common answer here was D, spironolactone. Right. So again, let's look at the question. 58-year-old Afro-Caribbean gentleman comes into the GP practice. Okay, fine. Age is a factor, and obviously race is a factor here within terms of hypertensive medications. He's got a history of asthma. Now that's a big important thing, and we'll explain why in a second. And he's currently trying Ramipril and indapamide, and indapamide is a thiazide-like diuretic. Amlodipine, so he's on a calcium channel blocker, he's on Ramipril, he's on thiazide-like diuretic, and he's on the rescue salbutamol inhaler for his asthma. His blood pressure is still not completely controlled, and now we have his USANEs, and his USANEs show that his potassium is running at 4.7. Now, the reason that's important is because, as we'll see on the next slide, The next step of treatment after you're on three drugs is to add in a fourth drug. And really you have a choice of spironolactone, which is a potassium sparing diuretic, which would be your ideal thing, a beta blocker and an alpha blocker. So the spironolactone is the thing that you would ideally use because it's got the best evidence. But you need to make sure that the potassium is below 4.5 in order to give it, because if you give a potassium sparing diuretic in a patient with high potassium, you can push them into hyperkalemia. So that's not what you'd want to do because this patient's already got a potassium of 4.7. So that takes spironolactone out, okay? So then after that, you would be going alpha blocker or beta blocker. So the choices here are bisoprolol is your beta blocker and doxazosin is your alpha blocker. Now, bisoprolol is contraindicated in this patient because they've got a history of asthma. And the reason why is because, remember what salbutamol does. Salbutamol is a beta agonist, which means it acts on the beta receptors in the bronchioles to cause vasodilation and smooth muscle relaxation and allow those bronchioles to open up and that patient to breathe. If you then block those beta receptors by giving bisoprolol, which is a beta blocker, then that means that you will stop that relaxation and you will cause actually bronchospasm in that patient. So bisoprolol will be contraindicated in a patient with asthma. So that only leaves you with your alpha blocker, which is doxazosin, which is your correct answer, right? So losartan, that's an angiotensin II receptor blocker, which you'd use if they're intolerant to ramipril. They're taking ramipril without an issue, so you wouldn't need to give losartan on top of that. Bendraflumethiazide is a thiazide diuretic, but they're already on indapamide, which is a thiazide-like thing. And really, we don't use bendraflumethiazide or anything like that anymore, or the thiazides anymore, because they're not very good. We tend to use the thiazide-like diuretics like indapamide. That being said, if they're already on bendraflumethiazide and they're fine with it, you would keep them on it, but that's kind of like a little subtle point to the side. So that's kind of your management of hypertension. So again, let's just go back to it. Again, PassMed, absolute beast, really, really good place that you should get a lot of your stuff from. First step really is the lifestyle advice. Lose some weight, don't put as much salt in your diet, and that's going to help. They're not going to do it, but you at least have covered your bases by saying that. And then after that, you take a look at the age and whether or not they have type 2 diabetes. So if they're below 55, if they have type 2 diabetes, the first thing you're going to do is give an ACE inhibitor, right? Irrespective of their race or anything else. If they're below 55 and they don't have, and they're not Afro-Caribbean, you would also give an ACE inhibitor. So that would be the next step of the process. If they're above 55 or they're Afro-Caribbean, and they don't have type 2 diabetes, then you'll go for a calcium channel blocker. And your examples are amlodipine and felodipine, ACE inhibitor, ramipril, and alapril, right? The next step is then adding, if they're already on the ACE inhibitor, you can either add a calcium channel blocker or you can add the thiazide-like diuretic. So that's usually indapamide. If they're already on the calcium channel blocker, then you have to add in the ACE inhibitor. But basically, you either have an ACE inhibitor or a calcium channel blocker and a calcium channel blocker, or an ACE inhibitor and thiazide-like diuretic. Still not working, you add in the third drug, and then the next step is to look at the potassium. And if the potassium's low, then you can safely give your low-dose spironolactone. If the potassium's high, you have to choose between an alpha and a beta blocker, as we discussed before. And if the blood pressure is not controlled on those drugs, then you'd be sending them off to a specialist. Is that all right? Now, hopefully that wasn't too quick. Was that about the right speed? Someone talk to me.
Yeah, that was fine.
Okay, thanks, Kamal. Appreciate it. I'm happy. Brilliant. Thanks, guys. Appreciate the feedback. All right, cool. So that's hypertension. The other thing that you can cover as well is hypertensive complications. So cardiac hypertrophy, that makes a lot of sense. You've got to work really hard against the systemic circulation. Therefore, the heart, as you increase resistance, your muscle gets bigger. That's what's happening here. Myocardial infarction, you increase the risk of myocardial infarction with hypertension. Heart failure, aortic dissection, things, again, stuff that you know already. Stroke, TIAs, vascular dementia, retinopathy, you have an increased risk of all of these things if you've got high blood pressure, and chronic kidney disease, because you're currently trying to batter that kidney with some higher blood pressure. It doesn't like it, and therefore it gets damaged. This is a nice little mnemonic that one of the guys came up with. So the 4 C's of hypertensive problems: coronary artery disease, congestive cardiac failure, chronic renal failure, and cerebrovascular accident. ACE inhibitor can be, yeah, perfect, brilliant. Yes, exactly. So yeah, usually the classic thing is that, doctor, I've been taking this Ramipril. It's just funny because my mum actually had the same thing happen. It's like, oh, I've been taking this new tablet. It's called Ramipril, and I keep having a cough. I was like, second year medical student brain kicked in, pharma done. I'd be like, Mum, you need to switch over to a losartan. And she did, and she lost her cough. It was brilliant. I felt like a proper doctor that day. So yeah, it's genuinely a thing. It genuinely happens. And that's the reason why you would switch over to losartan or any of the, or candesartan and all of that stuff. Sorry about that, guys. So next question, SBA 4. A 62-year-old gentleman comes for review. Recently, he has several episodes of syncope. He reports feeling groggy for only a few seconds after the episodes and felt slightly breathless with occasional chest pain. On examination, the pulse is 90 and regular, blood pressure is 110/86. Lungs are clear and there's a systolic murmur loudest in the aortic region which radiates over to the carotid. What is the likely cause of his symptoms? Brilliant. Thanks so much, Marish. And great. So a lot of you have gone for the correct answer, which is aortic stenosis. So main things, he's a bit old, episodes where he's losing consciousness and feeling a bit dizzy. He's got a bit of chest pain. Okay, so look at this. And I think, right, he's having episodes of syncope. So he's having like those blackouts and things like that. Now, the main things I'm worried about is that, is this a cardiac cause or is this a neurological cause of his syncope? He's reporting feeling groggy for only a few seconds after the episode. That's important because if it was something like a seizure, he'd feel like crap for a good few minutes to potentially hours after the seizure. And that, you know, after the blackout is taking place, and he's having chest pain. So this basically tells me that this is a cardiac cause of his syncope. Examination, his pulse is 90 beats per minute and regular. His blood pressure is okay. His lungs are clear, which is fine. And there is a systolic murmur loudest in the aortic region, which radiates to the carotid. The fact it says aortic probably points you towards one of these three things. The fact it's a systolic murmur means it's aortic stenosis or aortic sclerosis, and we'll talk about those in one of the next slides if you're not familiar with those. And the fact it radiates to the carotids mean it's aortic stenosis as opposed to aortic sclerosis. All right. Other murmurs that we've talked about, so mitral regurgitation is a pansystolic murmur which radiates to the axilla. Paroxysmal AF, so this is AF that comes in sometimes and then goes away. The classic symptom with that is palpitations. It does cause blackouts, but you would not really chest pain. The pulse would perhaps, they would have, I think, given you a bit more in terms of the pulse being irregular at this moment, and there wouldn't really necessarily be a murmur associated with this either. Aortic regurgitation, so this is a diastolic murmur. Well, he has a systolic murmur, so that's the reason why that's not the right answer. All right, so let's talk about valve disease and murmurs. And to be honest, this is pretty, I think you can break it down into make it like, oh, is it an egestion systolic, or is it is it an end systolic? Is it a late to mid stuff? Personally, for me, I just look at it and I'm like, okay, so in terms of, first of all, in terms of valvular disease, it's either stenosis, which means the valve's hard to open, or it's regurgitation, which means the valve's a wee bit leaky. All right. So in real life, I ask, is the murmur systolic or is it diastolic? And is it loud? Where is it loudest? Right. Because, and then that tells me all the information I need to know. If the murmur is a systolic murmur, I just think about the cardiac cycle. If it's murmurs occurring during systole and it's the loudest during in the aortic region, and that means that the aortic valve, which is opening usually during systole, is taking its time to open, and that's causing the turbulent flow, and therefore that's an aortic stenosis just by virtue of that. Similarly, if it was loudest over in this point and it was actually a diastolic murmur, then that means that when the aortic valve should be closed, there's a bit of turbulence, so the aortic valve is leaky, and therefore that's aortic regurgitation. Similarly, if I'm listening in the mitral region, the mitral valve should be closed during systole, but if I hear some turbulence, then I'm like, oh, this is possibly aortic regurgitation, mitral regurgitation. And similarly in diastole, if I'm hearing a funny sound during diastole, then that's when the valve should be opening really easily, but it's taking its time, right? So therefore it's stenosis, and that's mitral stenosis. And I think really for finals level, that's really all you need to know. And especially when it comes to actually doing the exams, that's really the level that I would expect a final year medical student to be able to come up with. You can split them. So the systolic murmurs, especially the ones on the left side of the heart, your atrial aortic stenosis and the mitral regurgitation are the murmurs that you're going to be expected to know and hopefully be able to recognize. You've got equivalent murmurs on the right side of the heart as well with your pulmonary stenosis and your tricuspid regurgitation, but they're generally pretty rare. The diastolic murmurs, the main one you need to worry about is aortic regurgitation because it's got a load of weird and funky signs and also it's a bit more common. But mitral stenosis is another murmur that you can get. And then you've got PR and TS as well. One thing that I did remember that might be quite useful for you guys is how to accentuate the murmur. And I use the mnemonic RILES for this, so which means right inspiratory, left expiratory. So right-sided murmurs are louder on inspiration, while left-sided murmurs are louder on expiration. And that's just the way the blood flows in and out of the heart during, depending upon the pressure provided by the lungs, etc. Wouldn't worry about that side of things. Just worry about right inspiratory, left expiratory, and RILES as your mnemonic. Metal valves sound clunky, even if you've not heard one before, like I hadn't. When I had it in my OSCE, I knew exactly what it was. It's that obvious. It sounds metallic and it sounds like a piece of machinery because it is. And if you're stuck, the other thing you could be asked is like, what could be causing this murmur? If you're stuck, rheumatic fever and infective endocarditis can cause almost anything. So you'll be fine to put in that as one of your differentials if you're presenting a particular case, basically. Is that all right? And I think that's really what your main things you need to know about valvular disease. We've put this into a bit more of a comprehensive table. So thank you and shout out to these guys, the two education officers for doing this. So aortic stenosis, ejection systolic loudness, aortic region radiating to the carotids, usually caused because people get old and then the valve calcifies. But if they're young, so like below 55 and they're getting aortic stenosis, then there may be a reason for that. And one of the reasons could be that they've got, instead of having 3 valves, they've got 3 leaflets, they've only got 2, and therefore it's just effectively more wear and tear on each valve, and therefore they're calcifying a little bit earlier. The other note is that you get this thing called a low rising pulse. If you imagine when that valve's trying to open, it's taking its time, and then when you're having the upstroke of the pulse, it just takes a little bit longer to be able to feel it than you would necessarily expect. Aortic sclerosis is basically aortic stenosis, but not quite as far, and it doesn't radiate over to the carotids. Mitral valve prolapse is probably your most common murmur. It occurs in about 5 to 10% of people. You have this click and then a murmur, and that's loudest in the mitral region. And the reason why it's common in people who've got connective tissue disease. What's happening is that the mitral valve, instead of opening and closing like this, it's going pop, open, pop, open, pop, open. And you can imagine that it's because these pieces of connective tissue are a little bit weak, and therefore if people have got connective tissue diseases, they're more susceptible to mitral valve prolapse, which makes a lot of sense. If that gets a lot worse, then that can lead to regurgitation. Speaking of regurgitation, that's a pansystolic murmur, so it's a loudest in the mitral region, and it radiates over to the axilla. It can be caused by prolapse, or it can be caused if someone's got papillary muscle rupture. And if you remember from your first year anatomy, papillary muscles are the muscles which are holding that heart valve into place. If they're rupturing because, for example, you've had a heart attack and a load of that muscle is now dead, then the heart is that valve is just kind of free floating like this, and it will do whatever the heck is going on rather than being restrained by the papillary muscles. And also, if you've got heart dilatation, so if you've got hypertrophy of the left ventricle, then the mitral valve leaflets themselves can kind of like pull apart like this because they're simply not long enough to be able to touch each other anymore, and therefore they become a bit leaky, they become a bit more regurgitative. So hopefully that makes a little bit of sense. Chest x-ray findings, so you can get cardiomegaly if you've got problems with the mitral valve because of your atria getting bigger as they're trying to push that blood back into the ventricles where it should be, rather than having more blood in them, which they would do. Because that blood, instead of going over through the aorta, is actually going into the atria, so the atria are ballooning. ECG findings, you can get this P mitrale or this M-shaped P wave, so M and mitrale is how I kind of remembered it. Other things that you need to know, aortic regurgitations, that's a diastolic murmur, which is loudest. So you can hear it here in the aortic region, but it's meant to be heard loudest in Erb's area, which is left sternal edge, third intercostal space, commonly found in connective tissue diseases, and obviously things like infective endocarditis, which we'll talk about later. It's got a load of funky signs. Apparently you get this collapsing pulse, a wide pulse pressure or difference between the systolic and diastolic blood pressures, because instead of in diastole, the backflow hitting the aortic valve, it's actually going straight through, and therefore the blood pressure drops further than it should do in diastole. You have these funny carotid signs called Corrigan signs, and essentially you will like see the carotid pulse in the neck, and actually I have seen that, so it is a thing. And apparently there's this head bobbing demusset sign. There's another thing where you can meant to be able to see the pulsations in the capillary beds, etc. It's all a little bit abstract and academic really, but you know, unfortunately it's just the way it is that you have to learn those things for exams. So just find it somewhere and learn them. But you know, the fact is that you know what the murmur is and you know what can cause it, and that's the main thing in my opinion. Mitral stenosis is a mid to late diastolic murmur with an opening snap. So it's diastole with a snap rather than systole with a snap, and that's your mitral stenosis. The one thing that you can get with some of these murmurs is this malar flush or flushing in the face. The reason that's occurring in mitral stenosis is because you're getting effectively a backflow, but actually what you're happening is that that's reducing the amount of blood flow that you're going to be getting to the left ventricle and therefore to the rest of the body. So these tissues up here become a little bit more hypoxic, and therefore there's more CO2, and CO2 itself is a vasodilator and causes your face to go pink. And that's really what we mean by this malar facies or mitral facies as they're called. So that's really that in common valvular issues. So in terms of management of these things, you would do an echo for diagnosis because that allows you to take a bit of a look at it. If they're asymptomatic, happy days, leave them be. If they're symptomatic, then you can think about surgery. So a metallic valve would be preferred in patients who are a bit younger because they can stay in for a long time, but you have to balance that with the fact that they will require lifelong anticoagulation because the metallic valve can cause shearing effects and a load of turbulence, which can increase your risk of a clot. You can also have a biological valve. If they're a little bit older, they have a tendency to calcify. So you'd use them in older patients because the likelihood is by the time the valve's calcified, they would have died of something else anyway. Or you can use balloon valvuloplasty for stenosis if the valve replacement can't be done. So essentially that's putting a long catheter into the valve. So if it's a aortic stenosis, so into the aortic valve, and because it's taking a little bit of time to be able to open, you would essentially blow it up a little bit, and then hopefully that'll I kind of think of it as it causes all the calcifications to shake off, and then it frees the valve and it can do its thing usually. And that's an option if you can't do the valve replacement. Obviously, the risk of that is that you do too good a job and they end up in aortic regurgitation. So is what it is. And obviously, if they've got any complications such as heart failure or arrhythmias, etc., then you would be treating that as we go along. And that's like your valvular disease 101, to be honest with you. Is that all right? Any questions for that so far? Okay. Keeping an eye out in the chat. I'm not seeing anything as of yet, so I'm hoping that that's all right with people. I'm going to move on if that's all right. Okay, so a 13-year-old Bangladeshi girl is brought into A&E profusely unwell. Her father tells you she's had a sore throat 3 weeks ago and yesterday complained of joint pain in her arms and legs. You notice that there is a widespread rash on her skin and she appears to be making strange rhythmic movements as you approach the bed. She is currently pyrexial and her ECG shows a first-degree heart block. She's got no known drug allergies. Given the most likely diagnosis, which of the following is the most appropriate treatment option? And just to mention that this is the rash that you are seeing when you go and examine her. Okay, so that's really interesting. So people have gone for B and people have gone for E as their top answers. So the correct answer in this particular patient is IV benzyl penicillin. So let's point out a few things. 13-year-old, so young Bangladeshi girl. And the reason I've told you she's Bangladeshi is that means that she's more susceptible to some particular diseases like tuberculosis, rheumatic fever, infective endocarditis, etc. Things that we don't usually see in the UK, but if they're not being vaccinated appropriately or if there are other things going on in the healthcare system, then maybe they're more susceptible to them. So that's the reason why I've put that in particularly there. She had a sore throat 3 weeks ago, and if you've done a lot of SBAs, you'll know that means either two things. One, this patient's got rheumatic fever, or they've got three things. They've got rheumatic fever, they've got post-structural glomerular nephritis, if they've got a nephritic syndrome developing, I think it's a nephritic syndrome, developing, it's nephrotic, can't remember, one of the two, developing 2 weeks after the sore throat, or they've got IgA nephropathy if they're getting the symptoms, the nephrotic symptoms, 2 days after they've gotten the sore throat. In this case, so that's the thing I'm thinking about. She's got joint pain in her arms and legs. That's kind of ruling out the nephrotic picture, but now I'm thinking, okay, this is maybe rheumatic fever. And you notice that there is a widespread rash on her skin, which looks like this. This is called erythema marginatum, and she appears to be making strange rhythmic movements. So that's my attempt at describing Sydenham's chorea, which is this like strange, semi-purposeful like dance thing that patients with rheumatic fever get. She's currently got a temperature, and her ECG shows a first-degree heart block, which again is one of the criteria for rheumatic fever. And she's got no known drug allergies. Now, we'll explain this in the next slide, but basically rheumatic fever is a autoimmune response against an infection which is provided by Streptococcus pyogenes. Can present with the nephrotic or nephrotic. Thank you, mate. Strep pyogenes, and with strep, you treat them with benzyl penicillin because that's what strep is susceptible to. All right. So chlorphenamine, so that would be if people are thinking about if this patient's had an allergy. Chlorphenamine is an antihistamine, but this is rheumatic fever. It's not an allergy. This patient's got an infection, so you need to treat it. Erythromycin can be used if this patient's penallergic, but they've got no known drug allergies, and that's mentioned. Flucloxacillin is good for staphylococcal infection, and P-odoxycycline isn't really indicated for strep. Is indicated for rheumatic fever, but you can use it in strep throat. But this infection isn't localized to the throat, it's gone systemic now. So you need to be treating it properly with IV benzyl penicillin. All right, let's talk about rheumatic fever. So like I mentioned, this is a autoimmune reaction against antibodies developed, autoimmune reaction effectively against strep pyogenes. So this is a bacteria. And the thing is, with strep pyogenes, or also known as group A strep, you get it's got a particular, the way that it looks on the outside of the body, of the cell, is similar to the way a lot of your proteins look in your body. So when the immune system builds up antibodies against the streptococcal bacteria, those same antibodies can also cross-react with some of your own, against some of your own proteins, and that's called a type 2 hypersensitivity reaction. So what you're getting is that a systemic immune attack of the rest of the body effectively, which is leading to the various symptoms that the patient's got. In order to diagnose it, you need to confirm that there has been a strep infection by using these various different ways, and you also use what's called the Jones criteria, which are basically symptoms that the patient can have, and if they've got more of them, then it's more likely that this patient's had rheumatic fever. There are two different types of criteria. There's the major and the minor criteria, and you need either 2 major or 1 major and 2 minor in order to be able to diagnose rheumatic fever. So one of the ways that I remembered it was Jones for major. So Jones and Jones criteria, that makes sense. So that's joint arthritis, which means that the joints are swollen and painful. So properly arthritic joints. Obviously the heart, that's a bit of a weak one, I'll admit. And this is about pancarditis. So you can sometimes hear a pericardial rub. And if you've not heard one before, then I'd encourage you to check up a YouTube video to check what that sounds like. These nodules, so these rheumatic nodules that you can see here, that's what the nodule looks like. That's the elbow joint, that's the nodule. Erythema marginatum, as described here, and the Sydenham's chorea, which we described in this particular patient before us. The minor criteria can be remembered with the mnemonic FAIL. So F is for fever, makes sense, it's got an infection. Arthralgia, so instead of swollen and painful, it's just painful. And inflammatory markers raised, and a lengthened PR interval if you've not already used the point for pancarditis because they've got a pericardial rub. And similarly, you can't, if the patient's got arthritis, you can't then use arthralgia as a minor criteria because you've technically already used it up. Similarly, if they've already used the major criteria for pancarditis, you can't use a lengthened PR interval because you've already talked about its effect upon the heart. So that's just something just to be aware of, really. In terms of the management of the thing, you need to treat the infection. So give them benzyl penicillin because it's a strep infection. So you give them Ben-Pen, and you can then switch that over to phenoxymethyl penicillin a little bit later on as well. And then you want to be treating the pain and the inflammation. So you would be giving NSAIDs, most commonly aspirin, for these patients. So SBA6, a 47-year-old IV drug user, comes into A&E with a 7-day history of a fever and fatigue. On auscultation of the chest, you notice a pan-systolic murmur, which has not been documented before. He's got no previous surgical history. Observations are as follows. We've got a BP of 87/56, heart rate of 112, temperature of 38.2, respiratory rate 23, oxygen of 97% on room air. Given the most likely diagnosis, isn't in which location is the murmur likely to be found? Rima asked a really good question. Shouldn't you avoid aspirin in children? Absolutely correct, because you can trigger Ray's syndrome. You'd probably have a word. You'd be thinking about it with these particular patients and may consider another NSAID in that particular case. I think there is one condition, isn't it? Kawasaki's, I think, in which you would give out aspirin, but that's something a bit different that you don't need to worry about. I would say that, you know, in majority of cases, in majority of adults, yes, you would use aspirin. In kids, you'd be a bit more careful. You might think about another NSAID. I hope that answers your question. Okay, well done. Right, so E is the most popular answer here. Absolutely fine. Okay, so I'm really glad you posed this, you picked that, because it allows me to do a bit of teaching. So 47-year-old IV drug user, okay? So the reason that's important is because if this patient's injecting medications through their skin, it's a little bit of, you know, judgment used here, but a lot of SBAs are judgment, if you've noticed. They're not likely to be doing it very safely. Okay, so so first of all, they're an IVDU. Okay, in my head, I'm immediately thinking infective endocarditis. I'm thinking they've got HIV or they've got TB. Like, those are the three things that immediately when I see that, that's the things I think in my head. Okay, we've got a 7-day history of a fever and fatigue. Okay, this could be any of those three things. On auscultation of the chest, you notice that he's got a pansystolic murmur, which has not been documented before. Okay, so he's got a new murmur. Likely this patient's got infective endocarditis. Is he septic? Yes, he is. His blood pressure's low, his heart rate's up, his temperature's up. And basically, just so you guys know, a temperature and a new onset murmur is infective endocarditis until you prove otherwise. So this patient's got infective endocarditis. Which location is the murmur likely to be the loudest? And this is a bit mean because I've not picked mitral regions or whatever, I've picked the actual locations. So second intercostal space, right sternal edge is aortic, left sternal edge is going to be pulmonary, third intercostal space, left sternal edge is the Erb's point, fourth is your tricuspid area, and the fifth midclavicular line is your mitral area. But so the answer in this patient is D, fourth intercostal, left sternal edge, which is the tricuspid area. The reason why this is the case is because if you think about it, the likelihood is that this patient has contaminated a needle, then that needle has gone into the skin, that bug has then gone through the circulation into the heart and then caused the infection to occur. The first valve that touches after the bug has gone into the skin, into the vena cavas, through the right atrium is the tricuspid valve. And therefore that is the valve that is most at risk in people who are going to be IVDUs. So therefore, in this patient, it would be the tricuspid valve. But you're absolutely right. The majority of the time, it's the mitral valve. And we'll discuss that a little bit later as well. But in this particular patient, because they're an IVDU, the likelihood is that it's gone systemic through the bloodstream, and the first valve it hits is the tricuspid valve. That's the most likely place it's going to have seeded. So, all right. Cool. So next, 58-year-old gentleman comes into A&E with a 7-day history of a fever and fatigue. On auscultation of the chest, you notice he has a pansystolic murmur despite a normal echocardiogram 3 weeks ago. He had a valve replacement surgery for his tricuspid valve 4 months ago, and his observations are as follows. BP 97/56, heart rate 114, temperature 38.4, respiratory rate 22, oxygen saturation is 95%. Given the most likely diagnosis, which is the most likely causative organism? Brilliant. Okay, thanks very much, Mahesh, for doing that for me. So majority of people have gone for B, which is the correct answer. Okay, again, break it down. 58-year-old gentleman, okay, a little bit on the older side, but not that old. He's come in with a 7-day history of a fever and fatigue. Not really telling us anything yet. He's got a pansystolic murmur despite a normal echocardiogram. Okay, he's got a new murmur and he's got a fever. So this guy's got infective endocarditis. He's had valve replacement surgery for his tricuspid valve 4 months ago. That's important because depending on which valve, because there are certain things that increase your risk factors for certain bugs, and valve replacement surgery is one of them. But this surgery took place 4 months ago, and that's important. And his blood pressure is a little bit septic, as we'd suspect, because this guy's got an infection. So the answer here is Staph aureus. Now, I was hoping that some people would have gone for Staph epidermidis, because that's usually the thing that people would get. That's usually the causative organism if you've had a very recent valve replacement. And I kind of think about it as, so staph epidermidis is a skin commensal. So I kind of think of it like, oh, you're cutting through the skin, you're cutting through the epidermis, so you're getting epidermidis, right? But after 2 months, beyond 2 months after surgery, the most common organism switches from epidermidis to Staph aureus, even if they've had a valve replacement surgery before. So Staph aureus is still the most common, and it is always, and now it is the most common cause of infective endocarditis throughout. Strep pyogenes isn't really, that's a rheumatic fever. Strep viridans used to be the most common, but now it isn't, though it is still pretty common. About 20% of cases are caused by strep viridans. This is a commensal that lives kind of in your nasopharynx, so it's commonly associated with people who've had dental work done before. And strep bovis is a really important one to know, because if you culture strep bovis from an infected patient who's got infective endocarditis, then that's a gut commensal. So it indicates that there's some pathology going on in the gut. So there's a bit of an abrasion. The bug is getting in through the gut and then making its way over through the bloodstream. And the common thing that you'll need to look out for then is that, does this patient have colorectal cancer? And I'll slow this down really quickly just so you can take a note. But if you are culturing strep bovis from a patient who's got infective endocarditis, after they're stabilized, the next most important investigation to do is to do a colonoscopy. So a tube up the back passage to make sure that they don't have colorectal cancer. And if I were you, I'd probably know that because it could come up. So yeah, that's that really. So infective endocarditis. So this is a busy slide, I apologize, but really that's an infection of the valvular leaflets, which we probably worked out. Mitral valve is most affected, then aortic, then mitral plus aortic, then tricuspid, unless they're an IVDU, and then pulmonary valve is the rarest one that's affected. The causative organisms are commonly these ones here. We've talked about which conditions will predispose you to which one of these things, but also there's the Hackett group of organisms, so that's like Haemophilus and Klebsiella, as well as Coxiella or other like typical organisms that you can expect to culture. The clinical features are generally pretty non-specific, but the main thing really is the fever plus a new murmur is infective endocarditis until proven otherwise. Other things that you commonly get asked to look for when you're doing a cardiology examination are these Janeway lesions, which are painless and on the palm of your hand. They're caused by septic emboli, splinter hemorrhages, which are at the end of the fingertips, and they're caused also by septic emboli. They look like little dashes here that hopefully you'll be able to see, and Osler's nodes, which are these painful little things which are caused by immunological deposits, so like the IgG and bug deposit that you're seeing, that you will get if you're developing an immune reaction to it. And the difference between these two are that these are painful, so ow Osler is the way that I was taught it, and I think that's pretty good. The way that you investigate it is by trying to apply Duke's criteria. And so again, that's another criteria you guys have to learn. There's two major criteria, so you can either have both of them to make a diagnosis, and there's 5 minor criteria. So if you don't, so it's either 2 major or 1 major and 3 minor or 5 minor. All right. The main thing that you would do makes sense is to take blood cultures, and you need at least 2 separate samples, and both of those need to be positive for a typical organism or 1 positive. Yeah, brilliant. Yeah, well done, Maharsh. So there's also a Duke's criteria for colorectal cancer staging, which is slightly different and definitely not related to this. But yeah, so blood cultures, which makes sense because you're looking at an infection. They both need to be positive for a typical organism, or for Coxiella, for some reason it's a little bit different and they only need 1 positive. And an echo, because you want to actually be looking at the heart to see if they can see the infection which is going on, and that can show some vegetations at some time. The minor, I really struggled to come up with a mnemonic. I came up with liver, but instead of an E, it's an F. It's about the best I could do, but it kind of, at least it works. So in terms of the minor criteria, L for lab, so blood cultures not meeting the major criteria, i.e. only 1 positive for a typical organism or not positive for a, they're 2 positives, but for an atypical organism, etc. Immunological findings, so that would be your Janeway's lesions. Sorry, it would be your Osler's nodes. If you've got nephritic problems, which can occur because of these emboli, etc. Because of these, the antibody and antigen bundles that are flying off. Vasculitic problems, so these are your emboli, Janeway's lesions, some hemorrhages here, Janeway's lesions. You can also get them lodging, and you can get retinal emboli as well that you can potentially see. It should have been an E, but it's an F for fever above 38 degrees C. and also previous risk factors, like if they've had a previous heart replacement, if they've got some sort of structural abnormality of the heart, or if they're an IVDU. And again, if you meet the criteria here, then you can pretty confidently diagnose infective endocarditis. How do you remember it? These two make sense because that's blood culture and echo. I'd probably remember the mnemonic and then be able to work out the rest of it for this, and probably use something like Anki to be able to just ram it into my head, and hopefully that will work. So that's that really for infective endocarditis. In terms of managing it, you want to give antibiotics. So this is basically straight from PassMed as to which antibiotics you would give in which state. It is a bit of a mess and it's a bit horrible. I wouldn't make it your priority to learn, but if you've got some extra time, then go for it. Really, if they've got a native valve, then you would give amoxicillin and maybe give some gentamicin. But if they're septic or they're penallergic, then you're going to go in with the big boy drugs and vancomycin and gentamicin, and maybe add in some rifampicin if they've got a prosthetic valve, because they just need a little bit more. Staphs are sensitive to flucloxacillin, streps are sensitive to benzyl penicillins, and yeah, generally, if they're penallergic, if you give vanc and gent, you're probably not going to go too wrong. There's one with rifampicin here as well. But yeah, I kind of remember that streps are always sensitive to benpen and staphs are always sensitive to fluclox, and that's got me fairly far so far, so that's kind of worked for me. If you can learn it in more detail, all props to you. There's also indications for surgery as well, and when I was looking at this, I was trying to organize it between, so why would we want to replace the valve? You either want to do it because it's going to provide a functional benefit, or because you're going to be providing an antibiotic benefit, i.e. you have to take the valve out because it's just so full of infection that it's better to just remove the valve entirely rather than keep it in there. So that's the sort of criteria that they're applying. If the valve is no longer competent, then you can remove it and take it out. If the patient's it's so incompetent that you've got cardiac failure, then it would make sense to replace the valve. And then for the antibiotic benefit, if they've got an abscess developing on there, if the infection is resistant to the antibiotics that you're giving, or if you've still got emboli, again, it's resistant after the antibiotics are being given, then it would make more sense to just, the antibiotics that you've tried and given are top line antibiotics, they've not worked. You have to just physically remove that source of infection and then treat, and then go along and go on and move on with that. So that's the other sort of indications that you would do for surgery. Is that all right for people? Is that okay? Or was that a bit quick? Okay. So I'm hoping that was all right. If I'm going a little bit too quickly, you want me to repeat anything, please just put it in the chat. I'm very happy to do so. So yeah, okay, cool. I don't see anything yet, so I'm gonna move on. Oh, hello, I see something here. Happy so far, thanks, Tom, I appreciate it. Okay, so a 24-year-old man has come to A&E as he has passed out in the middle of playing football. This is the 4th time it's happened. On auscultation, you hear an ejection systolic murmur, loudest in the left lower sternal border. His mother comes in and tells her the patient's father died at age 32 following a similar presentation. Given the most likely diagnosis, which investigation findings would be most likely? A, B, C, D, or E? This is a really tough one, I think. Thank you so much, Mary, for doing that. All right, good. So let me just talk you through it again. A young bloke has come in because he started passing out playing football. Right. As soon as I see that, I'm like, hokum. That's my first thing that runs in my mind. You hear an ejection systolic murmur loudest in the left lower sternal border. That makes sense because that's what you get in hokum. His mother comes in and tells you that the patient's father died aged 32 following a similar presentation. So there's a family history of this condition. So to me, this is screaming out hypertrophic obstructive cardiomyopathy. And the most likely, so I'll explain hokum in one of the next slides, but basically what you get is that you have asymmetrical hypertrophy of the left ventricular septum, which is causing this turbulence in the left ventricular side, causing a murmur, which is heard loudest in this particular area. And because the ventricle is now having to get bigger to accommodate for that obstruction, you've got hypertrophy of the left side, which is then causing the mitral valve leaflets to pull apart a little bit more and causing your mitral valve to regurg on you. So A is the correct answer in this particular patient. So they've got, you've got this mnemonic that I saw on, I think that Maharshi came up, you've seen it as well from PassMed, so Mr. Sam Ash, which stands for Mitral Regurgitation. Oh, this was systolic anterior something. It was, hang on, let me find it because this is one of my notes and I can't find it. Mahesh, if you can back me up here, then I would really appreciate it if I don't look so silly. Oh, it comes up on one of the next slides anyway. Chavani came up with it, brilliant. Okay, so Chavani, you're going to save our butts here. But basically there's this mnemonic here for terms of mitral regurgitation, asymmetrical septal hypertrophy, and this funny thing related to the mitral valve, which I'll explore in the next slide. So the point being is that it's mainly left-sided stuff that's going on causing the mitral regurgitation and hypertrophy, as we explained. The ECG wouldn't show a right ventricular hypertrophy. It would usually be left ventricular hypertrophy because it's all left-sided. A full blood count of HB76. So an anemia can cause murmurs and it can cause shortness of breath and syncope, etc. But it's less likely in this particular patient because there's no other reason as to why he's anemic. You know, if it was a woman, then they could be having really heavy periods, but this is a bloke, so unlikely. There's no mention of melena, etc. And also you've got this family history of a patient's father dying following similar presentation, which is leading you along the lines of HOCM. ST elevation could be seen, but more likely you're going to have the left ventricular hypertrophy and T-wave inversion. An echo, so aortic regurg and symmetrical hypertrophy, it's usually AMR and asymmetrical hypertrophy. Right, I'm going to look less silly now, hopefully. Okay, so hypertrophic obstructive cardiomyopathy, or HOCM. So it's a very common condition, occurs in about 1 to 500 people, and it's autosomal dominant, i.e. you're probably going to get, you've got a 50% chance of getting it if one of your parents has got it, essentially. So in terms of the pathophys, what's happening here is that you've got a defect in the genes which are coding for the muscle proteins, and it especially affects this particular side of the heart. So again, like I said, left ventricular septum. What's happening is that this septum then develops and gets bigger and bigger and bigger, and therefore it leads to an obstruction in the left ventricular outflow tract. So this bit here. Therefore, when the heart's trying to pump, it's trying to force blood past that obstruction, and that causes the turbulent flow or the murmur to appear. And because it's having to work a bit harder, the ventricle gets a little bit more hypertrophied, and therefore it gets bigger. Because it gets a bit more hypertrophied, you've got this mitral regurgitation because the mitral valves are essentially getting split further and further apart. And actually what's happening is that they can't touch each other anymore. And you also have the SAM part of the Mr. Sam Ash, which is systolic anterior movement of the anterior leaflet of the mitral valve. What this essentially means is that instead of that mitral valve leaflet here getting, closing whenever there's a contraction, it kind of flips and stays open. And that's your classic finding that you get in HOCM, just because of the way that the flow around this particular area is happening, and because of the hypertrophy, because of the stretching out of the mitral valve. So that's Mr. Sam, so systolic anterior movement of the la 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 la, and this is your ASH for asymmetrical septal hypertrophy. And also because you're getting the left ventricular hypertrophy, I kind of think it as those conduction pathways that are occurring within the heart are getting stretched and stretched and stretched, and it goes all horrible. And that can lead to your arrhythmias and your sudden cardiac deaths, which can occur. So in terms of presentation, it can be asymptomatic, but you can get these syncopal episodes that keep happening and you can't figure out why. Classic finding upon auscultation is an ejection systolic murmur, which is louder on the Valsalva, i.e. you get them to, breathe out against a closed glottis, or like they're trying to strain or the description is like they're trying to force out a really hard poo. That's the same sort of movements that you're doing during a Valsalva. But yeah, and the reason why is because that decreases the amount of blood flow going into the left side of the heart, and that causes the turbulence to just get a little bit worse. It's a bit more of an academic point, but the opposite happens. So both aortic stenosis and HOCM are ejection systolic murmurs, but HOCM gets louder with Valsalva, whereas aortic stenosis gets quieter with Valsalva. So that's just a sort of that's just a little point that you can pick up if you're really gunning. The other thing as well is that it can cause, because of these arrhythmias that can occur because of the left ventricular hypertrophy, you can just go straight into a VF rhythm, which will cause you to die. And that's basically what happened to Fabrice Muamba, who was that footballer who passed out in the middle of one of his marches and had to have CPR for about 70 minutes. He had HOCM, and that's why it got a little bit more, well known after that particular incident. So I just wanted to show you what left ventricular hypertrophy looks like on an ECG. And if you can see, compared to a normal ECG, this QRS complex is really, really deep and is really, really tall here in V1 and then tall in V6. And the reason why that's bigger is because the left ventricle is bigger, and therefore there's just more of it supplying this in electrical conduction, and therefore the signal on the ECG is just getting a bit bigger. The reason why it's downgoing in V1 is because if you think about where V1 is, that's taking the lead from here, and the heart, that's basically right next to the right ventricle. A downstroke means that the signal is going away from you. So the signal is going towards the left ventricle and away from the right ventricle, which is why it's a downstroke. On V6, now you're moving over to kind of this side, and now the signal is going towards you because it's a left ventricular hypertrophy, and that's why in V6 it's a little bit taller. There's various different ways of being able to quantify electrical left ventricular hypertrophy. The most common that I've seen really is if the SPQR, PQ, so the downstroke really in V1 is plus the upstroke in V6 is more than 35 milliliters, more than 35 millimeters in size, and that just indicates that that left ventricle is really, really massive. So that's kind of like your electrical criteria of left ventricular hypertrophy, but there are multiple different ones. That's just the commonest one I've seen around. You also see a little bit of here of T-wave inversion, and that's because there's a bit of it, because that ventricle is having to work really hard, that part of the heart is becoming a bit ischemic because it's getting too big for its boots really and can't really supply itself. See something in the chat. Thank you. Cheers, Shavini. Appreciate it. Yeah, so really, so that's, I just wanted to show you what left ventricular hypertrophy looks like on an ECG. It looks like this. So ECG findings like that, T-wave inversion, and you can have atrial fibrillation and deep Q waves, which is what you're seeing in that previous shot, in that previous ECG. Mr. Sam Ash, oh, I've actually got a slide that explains it. Mitral regurg, which you can see on an echo, mitral regurg, systolic anterior motion of the anterior mitral leaflet, and asymmetrical septal hypertrophy. The main thing that you want to do to treat it is to stop those arrhythmias happening, because you stop the arrhythmia happening, then you can stop the patient going into BF and you can stop that patient dying. So you give an ABCD, which is amiodarone, beta blockers to slow that heart down and help with symptoms. And then you've got an option between you've got options like a cardioverted defibrillator and a dual chamber pacemaker. So cardioverted defibrillator is something that they put in. It constantly monitors the heart, and as soon as it detects it going into a wacky rhythm, it whacks the heart with a massive great shock like you would do when you were CPRing them. Excuse me. And that hopefully will convert it out of that dodgy rhythm into a proper rhythm. And you can also have a dual chamber pacemaker to pace the heart, and if it's really failing, then hopefully that can help to keep the heart pumping. And that is the last slide.